Welcome, everybody, to another episode of Mind Matters, Navigating Head Injuries and Concussions. I'm Kiley Como. I'm a nurse with Shane Smith Law, and today we're speaking with Dr. Mbeo. Dr. Mbeo, it's wonderful to see you today.
So excited to talk about some of the novel treatments for traumatic brain injury. Now, for many years, one of the challenges with TBI has been establishing the diagnosis, and so having modalities that are replicable and just easy to administer, and then that are standardized. That's been in evolution, and we're there. We've got many things available to make the diagnosis. Now we get to the part where how do we treat many of the consequences of traumatic brain injury. Now, when we talk that, we're talking on the lower spectrum of that continuum of brain injury. When I say lower spectrum, I mean, if we're going to say the gradation was mild, moderate, severe, we're talking mostly about mild and moderate TBI as far as, some of these emerging modalities that I'll be talking about. Now, one of the most exciting modalities to help in the consequences of a traumatic brain injury is transcranial magnetic stimulation, TMS in short. So TMS in short, and TMS is a therapy that's been around for decades. In fact, in the 80s was a research modality, and we were studying brain and brain circuitry using transcranial magnetic stimulation. But as the years went by, as we understood more about transcranial magnetic stimulation, TMS took a front role in helping with treatment-resistant depression. So in fact, right now it is, as a therapy, transcranial magnetic stimulation is FDA approved, and it is insurance recognized, insurance reimbursed for treatment-resistant depression, and probably a couple other indications on hand as well. So transcranial magnetic stimulation. Now, the principle of transcranial magnetic stimulation is we're using pulses of magnetic energy. So we use a machine that helps generate pulses of magnetic energy, and we deliver those pulses to a part of the brain. So we go through a process of brain mapping, and we try to understand where different parts of the brain correspond to anatomical landmarks. And once we have that map generated and we know what correlates with which area of the brain, we use the special machine. In fact, you caught me in clinic right after a TMS session. So right behind me is one of those machines. I wasn't getting TMS, but then right behind me is a TMS machine, and so it's a portable machine, so pretty movable. It moves around the clinic, and then we use a wand that's attached to the main machine here. So this is one of many types of TMS machines, and we use this one to deliver pulses of magnetic energy to certain parts of the brain. So if what we identified was dysfunctions in circuitry in the frontal lobe, or perhaps connectivity between the frontal lobe, the parietal lobe, and the occipital lobe, then TMS would be used. Using this one, we're able to deliver pulses of magnetic energy to those parts of the brain that we figure could benefit from magnetic stimulation. Now, one of the questions I get when we talk about TMS, and as we prepare to deliver TMS therapy to our patients, is, Dr. Mbeo, is this electroshock therapy? And I say not by a stretch. So it is not electroshock therapy. In fact, transcranial magnetic stimulation is painless. So it's a painless sensation. Takes about 30 minutes for each session, and we go anywhere from 10 to 30 sessions, sometimes more, to try and achieve what we're achieving in helping the brain recover in different situations, including traumatic brain injury. As a therapy in traumatic brain injury, so some of the things that we target with transcranial magnetic stimulation include mood changes, which are pretty common in traumatic brain injury. So these disorders of mood regulation, we go all the way from heightened depression. We go all the way to PTSD, which is quite common after a traumatic brain injury. We go to heightened anxiety. That develops, all the way to other interesting indications in TBI as far as consequences. Tinnitus. In fact, there are certain protocols that we're able to program into the machine to try and help with this really difficult to help with symptoms, ringing in the ears. Many patients with traumatic brain injury will come and tell me, Dr. Mbeo, I've tried everything. Ever since I had that head injury, I've been experiencing this pulsating sensation, or this incessant ringing in one one or both ears, and then it keeps me up at night, and then things of that nature. And that's really difficult to treat with other modalities. TMS actually allows us to treat tinnitus, or to lower that the aggravation that's caused by refractory tinnitus. Headaches, so post-traumatic headaches. So there's actually protocols that we're able to use using transcranial magnetic stimulation to try and help with these refractory headaches. So really has a huge role in helping with the consequences of a traumatic brain injury. There are some ways that we enhance our accuracy with TMS delivery. So some of the ways, as we're trying to make sure that we're stimulating the appropriate part of the brain and delivering exactly what that part of the brain requires as far as magnetic impulses. So there's some ways. So EEG brain mapping, so obtaining an electroencephalograph and then using that and processing that into what's called a quantitative EEG, a brain map, which helps us understand the distribution of certain brain frequencies. That actually helps us target and customize how we deliver TMS therapy. And other ways, some people use image guided brain mapping, so MRI guided brain mapping to understand where the motor cortex is and where the frontal lobe is, and that also helps us with planning for treatment delivery. But once all that is done, once we've done the planning and we've appropriately selected the patient, we understand that they may be candidates to benefit from transcranial magnetic stimulation. We do the best we can to identify some of the contraindications. So hardware, so pacemakers and metal stents, metal clips, and things of that nature, contraindicated, so we don't use it in that case. Uncontrolled seizures, contraindication, and then there's a few others, but once we rule all that out, and once we rule out the presence of contraindications, we say let's proceed with brain mapping, some way of making sure we're accurate. Let's proceed also with obtaining a protocol, so what we program into the machine to deliver, and then we go through the sessions, and the sessions run anywhere from 30 minutes to an hour, and we start off with 10 daily sessions, and we can go even more. So a lot of data on the 10 days and beyond. So 30 to 36 sessions of TMS has been looked at. So quite exciting as far as one of the emerging treatments that we can use to help the brain in traumatic brain injury.
Fantastic. Yeah, I'm not as familiar with that modality of treatment myself, so I found that quite fascinating. Non-invasive, I'm always a big fan of non-invasive treatment measures, something you can do right there in your office. A lot of our clients have transportation issues. Obviously, if they've been involved in a motor vehicle accident, they may not have access to a car, and so it's nice to know that patients may not have to go to a different facility or a different doctor to have something like this. That's very exciting. The only thing, you answered most of my questions I was thinking of. One thing, how long do patients tend does it take for patients to tend to see relief?
Great question, and it varies. Like any treatment, it varies. And there are some patients who 2 sessions in will let me know, Dr. Mbeo, these daily headaches I was experiencing, my goodness, by day 2, day 3, the headache had reduced. The intensity was much less, and things were so much more tolerable. So some people will notice that pretty early, depending on the symptoms. So pretty early. In terms of mood, looking at clinical literature, so just all the data that was obtained when we studied the use of TMS in mood disorders, on average, for mood disorders, treatment-resistant depression, I'd say about 21 sessions in was where most people started to see the benefit. But we did see early responders. In terms of tinnitus, as we said, so that incessant troublesome ringing in the ears, the 10 sessions is typically what we need. Most people by about midpoint start to notice. About 5 sessions in, we start to notice a change in that ringing, that tinnitus that bothered them so much. Headaches we've talked about. As far as a few sessions in, we'll see. Sleep is interesting. So a lot of patients after traumatic brain injury will talk about how sleep impairments have become such an issue. Dr. Mbeo, it's difficult for me to fall asleep. It's difficult for me to stay asleep, and when I wake up in the morning, I do not feel rested. After a few sessions, in fact, probably 2-3 sessions into TMS, most people will start to talk about, that was the best sleep I had. The best sleep I've had was after my first couple of sessions of TMS. So also quite helpful in disorders of sleep. At least that's been my experience. That's one of the reports that we see. So about 3 sessions in, we'll start to see that.
Well, I'm not suffering from any brain injury that I know of, but I may need to come visit you for some of that sleep disturbance issue. That's fantastic. That's amazing. I wasn't aware of that. I would like to talk more about sleep disturbances and insomnia and kind of what you are doing for clients, patients that suffer from that, because we do see quite a bit of that. So yeah, if you could talk more about that, that would be fantastic.
That's exciting. So sleep disorders, also some of those hidden consequences of a traumatic brain injury, and many times when we don't ask as clinicians, our patients do not tell us, and many times the comment becomes, well, you know what, I didn't even think that was connected to my injury. But now that you ask me, I hardly get any sleep. When I go to sleep, I'll be up, just staring out into space for many hours. If I do fall asleep, little noise will wake me back up. When I wake up in the morning, I feel like I feel same as I felt at 10 p.m. last night when I tried to go to sleep, not rested. So sleep disorders are some of those common challenges that patients with brain injury will face, and there's various reasons. Sometimes it's related to pain and just trying to find positions of comfort, so that certainly aggravates it. But again, we've talked about traumatic brain injury as not just the mechanical, but the biochemical cascade that then follows that mechanical injury to the brain. And so when we talk biochemistry and we talk neurotransmitter changes, we talk circadian rhythm changes, our sleep-wake cycle changes, that's actually pretty common. That's pretty common as far as a deficit sleep disorders. And so one of the important screens when we're evaluating patients that come in with concussion symptoms is doing best we can, not only on history, just history, asking about what their sleep is like, just being purposeful. What is your sleep like? Tell me about your sleep is one of the questions I asked. But using validated, standardized questionnaires in screening for sleep. So one of the ones I use when I assess patients with brain injury is called the Epworth Sleep Scale, the ESS. So just trying to understand about sleep quality. We also use the Pittsburgh Sleep Quality Index, PSQI, so another standardized battery of questions that really helps us understand, sleep-related disorders. And when we talk about it, after we get that data, usually with the sleep quality indices, as we go through the questionnaires and then we're talking through what did we find, what did this reveal about your sleep, many patients say, well, you know what, I didn't think that this was connected with the traumatic brain injury I suffered. I didn't think about that. One of the questions I ask is, well, let's think about this. So before the injury, before the brain injury, what was your sleep like? And think about your sleep after. And most of the time, it's, well, my sleep was average. I don't think I had disordered sleep. And now I can tell you for sure, my sleep is terrible. So they're able to relate that. They're able to relate that change. Why is it even important to understand what sleep can do and understand the presence of sleep dysfunction in TBI? What we are learning is that poor sleep and disordered sleep sets us up for a future of cardiovascular compromise, so heart disease, blood pressure changes, so really difficult to control. Hypertension becomes one of the issues patients with poor sleep will face. Issues related to neurodegenerative processes being a lot more prevalent. So think about it. In our sleep, the brain gets rid of all these they call them the toxins that build up, and all the things that need to be sequestered and eliminated. That happens in our sleep. That elimination happens through a system we are slowly understanding more about called the glymphatic system. So the glymphatic system, the brain's cleaning, the brain's sewer system, we'll call it. The brain's way of getting rid of waste that build up. That system is active when we sleep, and when we do not sleep, these things that should be eliminated in a natural way through the glymphatic system do not get eliminated, and they accumulate in the brain. And further down the line, patients with traumatic brain injury who develop sleep dysfunction now get themselves set up for neurodegenerative processes as they accumulate all these bad elements in the brain. Talk about memory decline related to processes like Alzheimer's or other neurodegenerative processes. So it starts to it adds up, has a snowballing effect. So a brain injury, impaired sleep, and further down the line a setup for neurocognitive troubles further down the line. Many times also dysfunctional sleep in our patients also correlates with just day-to-day poor function functioning. So poor functioning in terms of cognitive functioning. Dr. Mbeo, I have to, write lists to keep up with things nowadays. I need to, have post-its all over. I never used to have that as an issue. But I walk into rooms and leave my keys there and have no idea, where this and that, why I was in that room and where I left this and that object. And when we talk about what their sleep is like, we realize, my goodness, there's a correlate between your poor memory function and just day-to-day, lack of sleep or sleep deprivation. And so that's important. So it's important to assess this sleep dysfunction that arises because of a traumatic brain injury, and it's important to address it because there's downstream consequences. And we've talked neurodegenerative, but there's also certain malignant processes. So unfortunately, a higher likelihood of developing malignancies has been seen, or cancer processes has been seen in patients who long-term spiral into poor sleep. So poor sleep really needs to be assessed and addressed.
Yeah, that's I think most everybody that would be listening or watching us here has experienced poor sleep at one time or another in their life, and certainly can at least understand on a basic level what missing a good night's sleep is like. But trying to imagine dealing with that day in, day out has got to be incredibly challenging. So for anyone listening who is dealing with that or knows somebody who is a loved one, a friend, is encouraging and hopeful to hear and learn about some of these new, as you call them, emerging technologies that are being used to treat, other than guessing or pills or something like that. It's these are targeted approaches. So this is fascinating. Well, that's going to do it for another episode of Mind Matters, navigating head injuries and concussions. Thanks again to Dr. Mbeo for sharing your knowledge and your expertise with us today. To our audience, please remember to like and subscribe to our channel and stay up to date on all of our latest content, and hit the bell for notifications. And remember, if you're in pain, call Shane at 980-999-9999.
In pain, so I call Shane. 980-999-9999. In pain, call Shane.